Hi everyone, and welcome to the second session of Digitodontics Webinar Series. This is Mahmoud Al-Bashti with you today from Digitodontics International Academy. It's our pleasure and honor to welcome our guest speaker, Dr. Noland Naidoo from the Eastman Dental Institute, UCL, London, United Kingdom. Dr. Naidoo will share with us his experience in digital pathways to improve efficiency in the management of head and neck oncology rehabilitations. Dr. Noland is a clinical lecturer in prosthodontics at the Eastman Dental Institute. In 2005, he graduated with the Bachelor of Dentistry from the University of the Western Cape and a postgraduate diploma in implant dentistry in 2007 from the same university. In 2016, he graduated with the Master of Dentistry in Prosthodontics from the University of the Witwatersrand. From 2016 to 2022, he was the director of Santon Prosthodontics in South Africa. From September 2022, Dr. Naidoo moved to the Eastman Dental Institute to work as a clinical lecturer in prosthodontics. Dr. Naidoo is an expert in the field of dentistry and has dedicated his career to advancing digital solutions in head and neck oncology rehabilitations. With his vast knowledge and expertise, he has revolutionized the way we approach patient care and treatment. During this webinar, Dr. Naidoo will shed light on the latest digital techniques and pathways that have transformed the efficiency of managing head and neck oncology rehabilitations, from cutting-edge imaging technologies to innovative treatment planning. This webinar promises to be an invaluable resource for all dental professionals. So just before Dr. Noland starts, I would like to raise your attention that you can write down your questions in the Q&A part. And after Dr. Naidoo finishes his presentation, he will be happy to answer all these questions. So once again, I would like to welcome Dr. Noland Naidoo. Noland, thank you for accepting our invitation, and I think the stage is yours. Please.
Thank you so much. Let me say thank you to Dr. Al-Bashti for inviting me here. It's a real honor. And I've watched the previous webinars, and it's really a privilege to be amongst the speakers that have been delivering these kind of webinars. So today we're going to talk about digital pathways in how it can improve the efficiencies in oral rehabilitation for head and neck oncology patients. I always like to start with a bit of a disclaimer, that just to say that all the views and opinions presented today is my own, not that of the UCL or UCLH. I am a lecturer at the Eastman Dental Institute in London. I do have consent to share the photographs that I'll be sharing for teaching purposes, and none of the photographs have been changed in any way except for cropping or alignment. So just a little bit about myself. As has been mentioned, I'm from South Africa. I studied in South Africa, and I did my postgraduate prosthodontic training at the University of Witwatersrand. And here's one of the beautiful buildings at the University of Witwatersrand. An interesting thing about South Africa is that we've got a population of 62 million people. And if we look at the density map of South Africa, you can see the population is concentrated in certain cities. And I've been privileged enough to live in 3 of these cities, namely Durban, Cape Town, and lastly, Johannesburg. I spent the last 10 years before moving to the UK. What we find in all these cities is the stark contrast between the haves and the have-nots. And often you'd find them in very close proximity. So often the type of treatment that we'd be providing it for both ends of the spectrum, and our outcomes need to be geared towards, regardless of who we're seeing, we're providing the same level of care, because cancer doesn't differentiate. Now, this is just a collection of pictures of patients I've treated over the years, and you'll see a vast array of presentations of the different types of oncology that we saw in private practice and at university. And our goal was always to try and rehabilitate the patient so that they can integrate back into society. Now, because of late presentation and cultural biases, as well as superstitions, patients have various different reasons for not wanting to come to the hospital, which is why often we'd find in South Africa that there's very large lesions that present, or some of these cancers are so rapid that they present with extensive deformities in a very short space of time. So just some background, we know that head and neck cancer is the 7th most common cancer globally. There's about 325,000 deaths annually. In Europe, which is relevant to me now because I'm in Europe, there's about 15.6 deaths per 100,000, which is on the climb. 90% of all head and neck cancers are squamous cell carcinomas, and there's an increase in incidence related to the rise of oropharyngeal cancers. And now that we know a little bit more about HPV, we're getting to see a little bit more of those related cancers. Often the effects of primary oncology can impede rehabilitation goals, especially the way things were done previously. I think now as we're moving forward, working with MDTs, so multidisciplinary teams, we're communicating a little bit better, but not everyone's privileged enough to have those teams around us. And so often the goal of treatment would be to remove the cancer, but then the patient's left with what's left behind, the deficit. There's different approaches. So one of the approaches used to be that they just resect the cancer, and that was good enough because in terms of success from that approach, being cancer-free was a success. But we know today that patient quality of life is quite important. Another approach would be reconstruction. So not a rehabilitation, but let's say a mandible was removed, there'd be a reconstruction plate. So it would be continuity of the mandible or flat place in the maxilla if there was a maxillary defect. But that didn't really give the patient back a similar or equal quality of life. It just closed the defect and not necessarily in a symmetrical way that they could reintegrate into society again. So where we want to be basing our treatment approaches is really at the rehabilitation level, where it's a functional rehabilitation that allows patients to still chew, swallow, and talk normally. And so our goals is, number one, oncologic resolution. So I mean, there's no point rehabilitating the patient if they still have the cancer. So we really want to have them cancer-free. We want to try and limit the amount of toxic effects and side effects where possible. It's not always possible. The functional and aesthetic result is really an ideal outcome. And that allows patients to reinsert themselves into society, be able to go back to work, be able to talk to their friends. And that really relates to the interplay between those last two. If we look at some of the consensus statements from the 2014 meeting of the International Academy of Orofacial Rehabilitation, they agree with what we just said. They said cure is paramount for patients, but functional outcomes do influence the patient's quality of life. Surgery, therefore, has to be tailored to maximize the functional outcome. And as early as possible that we can rehabilitate the patient, these patients are able to better adapt and adjust to the post-treatment defects, which then ties in with their functional outcome, which then ties in with their quality of life. Simon Rogers and his group in Liverpool have done some amazing work over the last many decades, and some of their publications look into what patients actually care about, and they develop this patient concerns inventory. And here as well, this inventory highlights the fact that yes, patients want to be cancer-free, but once they're cancer-free, most of their concerns are related to oral function, speech, and reintegration to society, which a lot has to do with how we deal with the patient from day one. All right, so when we're planning for the patient, when we're doing our diagnostics, there's different levels at which we can approach this. Again, in the past, we had that anatomical reconstruction level where the cancer was just removed, and after everything was removed, without any other planning except operator experience, then the patient was reconstructed. And we know from the literature that this doesn't always give us an ideal outcome. In fact, more than likely, it gives us a less than ideal outcome. And asymmetry is often an issue, as well as patients' ability to function. So with the advent of technologies, CBCTs, several different planning softwares, we are now able to digitally plan what we're going to do, especially with the communication skills that we're developing as teams. We can talk to each other, understand where the reconstruction slices are going to be, or where the resection slices are going to be, so we can plan our reconstruction, and more than likely be close to that, because we know that when we get into, depending on how long the patients waited between diagnostics and treatment, the cancer could have grown, and so margins would need to be repositioned. But I think digitally planned and unguided is also a thing of slowly becoming the past. And most of us are at the level of, when we're doing this kind of treatment, is that we're digitally planning and we have some form of guide. We haven't gone to the fourth level where it's fully guided. Not always, it's not always possible. And this is because of the unpredictable nature of the type of surgery that we encounter when we treat these patients. But I think, again, if we can develop a seamless workflow where from time of diagnosis to time of surgery to time of reconstruction, we limit that time frame, I think fully guided reconstructions will become something more commonly used for cancer patients, and maybe more predictable as well. There's already lifetime navigation that's available, but I think as it gets better and with the increased ability of artificial intelligence and robotics, we may get to a point where it's planned, and a lot of our guidance will be taken from live navigation and robotics. But I don't think we're there yet. So let's talk a little bit about the maxilla. So maxillary neoplasms, although they're less common than mandibular ones, they have the greatest challenges to us as prosthodontists and to our patients, because there's often when the defect is left, there's a lack of support and there's lack of space. You know, the soft tissue that we're dealing with is less resilient than in other areas of the body, and the inability to be able to form words, the inability to be able to swallow, greatly affects the patient's quality of life, and this gives the patient more stress than most other areas of the body. So always nice to classify defects, and there've been many different classifications proposed through the decades for maxillary defects. One that's used commonly in the UK is the Brown and Shaw classification. Where I trained, we used the OK classification, and we used it because it was something that we could relate directly to how we would reconstruct the patient. It was fairly straightforward and simple for us to understand. And one of my mentors, Dale House, has also been pivotal in modifying this classification, especially with the advent of implantology and the zygomatic implants and zygomatic oncology implants, where the class 2 defects could then also be, class 2 and class 3 defects could also be prosthetically obturated and not just with free flaps, which is a very useful tool, because not everybody has the facility or the access to having a free flap done, and the time and expense of doing that versus a prosthetic obturation is quite stark. So here's just examples of the different types of maxillary defects according to the OK classification. Class 1, class 2, and class 3. And you can see with the class 1, if a patient is not going to receive radiation, it's fairly straightforward to be able to create some form of obturation to close that defect and give the patient some semblance of normality, being able to talk and swallow. Whereas with your class 2 and class 3, you have less support, which makes it a little bit more difficult to provide a prosthesis that's moving on that tissue, and we're looking for ways of making it more rigid and decrease the movement, and that's just where implants help us greatly. But let's look at the class 1 defects and conventional prosthetic obturators. The surgeons really like it because it's in, quick out. There's less expertise that they require to just remove the tumor, and with implants, if that becomes an option for these patients, there's more bone availability to place them, so that there's more chance for an implant-borne obturation. But for a prosthodontist, it's not that straightforward. Generally, you do need some expertise to understand how to reconstruct these. Not every patient's the same. In fact, every patient is going to have some nuance of difference in how you reconstruct them. Speech can become an issue where we've got to work with the patient. You can see here with the obturator, we've used the soft liner just to try and adapt that obturator to try and decrease the nasal resonance so that the patient can form normal speech. And not always easy to masticate with these ends, like wearing a denture, but one that has less support. And patients have to take it out. So the psychological burden can be quite great, especially for younger patients or patients that are quite aesthetically aware. I mean, how many of us have had patients where they've said that their husband's never seen them without their denture? Now you can imagine if they have to take this out to clean it daily or a few times a day. And as soon as you introduce radiation into these patients, a tissue-borne obturator becomes quite a tricky thing to have in place and can create quite complex problems down the line. But where digital technology has helped us, and this is quite a small defect, the patient had a tumor in the hard palate, soft palate junction, and it's been reconstructed a few times, but they could not close that defect. And so the patient came to see us. He's had an obturator previously. He was unhappy with the obturator. It's one of those clear obturators that was made by the lab, which is quite bulky and thick. It affected his speech. He was a young patient. And with scanning, we were able to scan the patient in a fairly accurate, reproducible way. And using ExoCAD, we were able to design an obturator with a uniform thickness of 0.5 millimeters and have that mold. And for this patient particularly, it was life-changing because as soon as he put it in, he said these words were, "I don't even know it's there," which translated to his immediate improved perception of his quality of life. The other advantage of this is that because we have the file, if we ever broke it, we didn't have to take new impressions. We could just remill it. And I think this is where digital technology is really helping us, is that we could always have a file on system because it's just something that takes up hard drive space. And with printing being more accurate now, we can just print models when we need them, as opposed to having to retake impressions. Because often we find when you're making obturators, those casts generally do get destroyed or damaged and they're not reusable. So we talked a little bit about implants, and we look at a conventional way or a less conventional way of rehabilitating these patients with implants and a removable obturator. So what our philosophy was at the university and in our practice in Johannesburg was that we would try and make sure that where possible, we give the patient a fixed prosthesis. But because there's a defect there that we have to obturate, we create a prosthesis that you can just remove the palate and that can be relined and cleaned. So the patient never had to lose their symmetry of their face, and it could give them a better sense of self-worth and be able to integrate into society fairly easily. And patients did enjoy that rather than an entire removable obturator. But what we had to do before we had all these technologies talking to each other is we'd have to first remove, especially in non-malignant cases, remove the tumor, wait for healing, then take new scans, then print those models, do model surgery. We could plan on the software, but we couldn't always translate it to the patient. And also the type of guide that you'd make for this, is it bone supported, is it tissue supported? There was all these different factors that really made surgery quite complex. But yet, even with all of that, we were still able to, with good surgeons and good teamwork, provide the patient with something like we have here. That was a fixed dental alveolar prosthesis with a removable obturator that's able to be cleansed and adapted as the patient needed it to be adapted. Now, with this patient, we've had several visits to get to this point. Here's a patient that had a malignant disease. I saw the patient for one visit. We had an MDT meeting with all the team players, the maxillofacial surgeon, the ENT, the plastic surgeon, the oncologist. Everyone had all the diagnostic information. And in a matter of 2 days, was able to diagnose, treatment plan, and formulate a plan that was accepted by the funders, and then book surgery for this patient. So the next time I saw this patient, the patient was in theater, which is 2 weeks from here. So that drastically reduces the time frame between diagnosis to treatment, which is what we want, especially with malignant cases. With the help of simulation software and simulationists, this is freeform. You can use other softwares, Materialize. We're able to plan where we're going to have our resection, look at what was resected, be able to remove that piece, create an STL file, and actually at the time of resection, compare whether what we planned to remove was what we removed. And I mean, we always have frozen sections at the time of surgery, but it's very useful to see if we've removed more or less and to gauge how well we plan so we can audit ourselves so that we can plan better if we need to for the next case and to see where things have changed. We're also able to overlay that STL file of the intraoral scan onto the planning software, plan exactly where we wanted the implants to come out. If we chose to now, we could have made a surgical guide that was either tooth supported or tissue supported. Because the software has improved, it can be stackable. What we also do as a part of our protocol for zygomatic oncology implants is that you can't place the implant head exactly where you place it for a patient with a normal alveolus because there's no secondary stability. And we're also trying to decrease the bulk and ensure that the screw axis is coming out in the envelope of the occlusal plane. And so it's quite critical that when we do this, it's coming out, we plan it to come out at the apex of the teeth. So the teeth from the contralateral side is superimposed onto the defect side, and we make this device that is very helpful in surgery. And here you can see it on the model. So these are just guide indication pins that are going to help us decide where we want the implant screw access to come out while placing it into the zygoma. That gets transferred into the mouth. And because we've done the model surgery, we've already practiced, so we know what angle we need to go in at. And you can see here that it's more or less where we've planned it to be. It's helping us get closer to an outcome that's going to be predictable and acceptable for the patient. Implants go in, impressions taken. And we also make, before surgery, what we call a surgical obturator. So this is prefabricated based on the STL files that are socketed and manipulated in Exocad or similar kind of program. This gets placed onto the STL model or the stereolithographic model. And then this gets plated in place at the day of surgery. So the patient wakes up with a set of teeth. The patient's able to talk. And even though they'll have a nasogastric tube in, if they chose to, they could swallow as well. And this is quite useful, especially from a patient psychological perspective. But because we can pre-bend, everything's pre-made, we can pre-bend these plating plates on the model and then just transfer that at the time of surgery, it really decreases the amount of time and makes things a little bit more predictable at surgery. And here we have the surgical obturator being placed and plated in place, and that'll stay in for 2 or 3 days while the lab is fabricating the prosthesis. Then we go back to theater, or we could do it under sedation, but more comfortable for these patients under the general anesthesia, and takes less than an hour. The surgical obturator is removed. And again, this very similar prosthesis design to the one that we showed previously, where there's a fixed dentoalveolar prosthesis with a removable palate, and that gets relined as we need to optimize the patient's speech. And there's the patient 7 days after surgery with the prosthesis in place, ready for her radiation. So Chris Butterworth, again, part of the Liverpool group here in the UK, he came up with this, or he developed this technique where you can perforate a flap that obturates the defect, so we can eliminate the need for a prosthetic obturator. And he's done this fairly well and consistently for the last 10 years. So we've also tried it following his protocols. And this is why it's so critical for me that we get the implant screw access coming out in the envelope of the occlusal table. So when we convert the patient from a dentoalveolar prosthesis like this with a removable obturator to just a dentoalveolar prosthesis, we're decreasing the bulk of the prosthesis. So the patients are relatively normal. The speech isn't severely affected with the bulky prosthesis, and they can integrate and almost function as if they've never had the defect there. So here's just an ALT flap for a young patient of mine being placed and healing. And as you can see, as it starts to heal, it starts to decrease in bulk. But we can pre-make this prosthesis. So this is 3 weeks after the surgery, and the prosthesis went in on the day of surgery. So the patient again wakes up with his teeth in place, and that does leaps and bounds for a young patient to be able to wake up and talk to his friends and talk to his family without having to worry about there's a big hole in my face and my face is dropping in. After a bit of healing, you can see that the flaps really reduced in size and matured quite nicely. Good soft tissue around the implants and the endosseous bone, and now ready to be rehabilitated. And I had left the practice by the time the young patient was ready to be rehabilitated definitively. So thanks to Dr. van der Linde, who is now there holding the fort for me, taken over from me, and he's done this definitive prosthesis, which patient's ecstatic with, a little bit of composite on the contralateral teeth. And if you didn't know, you wouldn't know this patient had a huge maxillary defect. And I think this is what we're trying to do, is that regardless of the treatment, if possible, reintegrate the patient into society where there's no difference between them and their peers. Looking at bone-free flaps, we've done these as well. They work really well. They're a lot more labor intensive and take a lot more time and a lot more costly. But here again, we go through the whole treatment planning process of planning everything digitally first, creating guides. So this patient received a modified Rona technique, similar to what they do in Alberta with ISRM. So the implants are placed in the fibula before it's resected and placed into the maxilla or mandible. Here's the guides that have been fabricated, tubule coming out, fibula being harvested, implants being placed in place, waiting for it to integrate, and then the patient rehabilitated. There were some complications in this case with position of the implants because it was relatively new for the team at the time, but as things improved, the placement became better. But you really need a good team if you're going to do this well, and developing that team is critical. We can also do this in the mandible. Here's a patient with a really extensive lesion causing quite a bit of asymmetry in some of the planning process. You can see here what the simulations did is they mimicked the mandible from the right-hand side onto the left-hand side. And I think this is quite routine now to try and guide us in how we're going to recreate that contour of the patient's face. And then we overlay the fibula to plan our resection, and we know there's certain dimensions that we want to maintain to ensure that that fibula doesn't die and integrates well. Cutting guides being created, and here's the patient receiving the surgery. Unfortunately, the patient was from the Congo, and we didn't get to follow up with her before I left. But here's another patient who had osteomyelitis and a failed flap. And I'm just going to play a video just to show you how we plan this case. So this video is sped up by 16 plus times, and a lot's been snippeted out. But the planning process live via Teams took about an hour and a half with the entire team giving the input. You can see the mandible is repositioned, choosing the right length for the fibula. You want to be at least 8 millimeters from the ankle, I'm told. The cutting guide is created in such a way that everyone's happy that when the blade goes in, it's a nice, clean, neat cut. We also want almost a jig to reposition the mandible in the right place so that when we section it, we create this stabilization guide. So that stays in place during the entire surgery and only gets removed after everything's been plated in place, after the fibula's been plated in place. And so just to show you, that's the stabilization guide in place, the fibula being plated. And this is the patient 9 months down the line. No teeth yet, as we chose in this case, just to place the fibula because we weren't sure whether this was going to take, because the patient had some medical comorbidities that put it in a high-risk group. But now she's ready for implants to be placed, so hopefully that'll be done in the next few months. And we were able to rehabilitate her, give her some teeth, be able to allow her to smile. So just something different. So we look at the extraoral rehabilitation, the prosthesis that we can make for patients. Here's a patient that presented to me when I was a student at training. We did a bit of software manipulation. So this is the only picture that's been manipulated to mimic the right eye. But this is the value, is that now I can give this to the technician, the anaplastologist, while we're working together, so that when he's not with me or with the patient, we can create a prosthesis as close as possible to this. And then the end result, maybe not as good as the digital manipulation, but a fairly acceptable result. I think we added a little bit more eyebrows into the prosthesis. We could have had something that moved a little bit closer. But today we can use things like face scanners to also do this. And then photogrammetry with the use of cell phones. I mean, you know how powerful our cell phones are, and this has been shown. But Rodrigo Salazar in 2016 already. So what he did there with the printing wax was unbelievable. And I think with the technology improving, we can only get better and better from there. Extraoral ears, we've also done the same thing where we've mimicked the ear, put it onto the contralateral side where the defect is, looked at where there's the best bone available for extraoral implant placement, place them, let them integrate, create bars, and create prostheses. And today I'd probably try and create this prosthesis digitally because the tools are there and available and quite predictable. So as we're getting towards the end of the presentation, the digital pathways are expanding, and there's so many different aspects and facets that are available to us, not just for dentistry, but for maxillofacial prosthetics as well. And I think with the integration of artificial intelligence, and we're already seeing how that's improving the efficiency of what we do with segmentation and implant planning and implant guides. I think the possibilities are endless, and I'm really excited to see how this grows to improve our patients' outcomes, to improve their quality of life, and to really just make the process as painless as possible. Right? My mentor, Dale House, always used to say to us, never make the treatment of the disease worse than the disease itself. And I think that's our drive. And that's where my focus has been in the last 10 years. And this is why I've integrated the technology the way I have, always trying to ensure that what we do is for the patient's benefit. And none of what I did or do is possible without a team, and the team is extensive. And I really want to thank the team for everything I've shown you today, because I could never have done any of that without them. And if you're thinking about doing this kind of work, you really have to have the right mix of the team together, and people to hold you accountable to ensuring that you make the best, do the best for your patients. All right. And if there's any questions, I'll be happy to answer them. I'd really like to thank you. And Mahmoud, thank you again for allowing me to share that. I would like to say that by no way am I an expert in this field. I'm learning every day. And there's lots more out there that I haven't shown, that I haven't done. And I look forward to learning them all.
Thank you so much, Noland. It was very, very interesting and very inspiring. The technology that you presented, it was very, very nice to engage our audience to know about all these kind of technologies, as you say, merely for the benefit of our patients. So once again, if there's any questions, please write them down, and we will try to answer the questions. So Noland, I know your expertise more in zygomatic implants. You have very good experience with the zygomatic implants. And I guess for the near future, for the oncological patients, the zygomatic implants can play a great role to improve the function and aesthetic for the patients who have the oncology and treated with the surgical resection of the tumors. And with nowadays technology, it's possible to plan the entire zygomatic implant-based treatment. Can you touch on that, please?
Yeah. So I think it's really changed the face of how we treat these patients, because if we look at the zygoma, if you're having a maxillary tumor resected or mandibular tumor, the the zygoma is relatively spared, even if there's going to be radiation applied to the patient later on. So it's a really good site for an implant to integrate into. There's some parameters we have to assess when we're looking at that zygoma as to how many implants we could place in there. And the flexibility that zygoma does mean that we need to try and get cross-arch stabilization where possible, or at least 2 endosseous implants into the alveolus if it's going to be ipsilateral side. But because of the technology improvement with the zygomatic implant, you could see the one that we used there, the shaft was smooth, because there's no bone to integrate into, which means that even if it's exposed, patient can clean. What this does mean, though, is that what we're able to do is we go into theater at the time of resection with all our pre-planning, place all those implants in as we plan, place the zygomatic implants in, place endosseous implants if we needed to, or like the last case I showed, the zygomatic implants is like quad zygomatics, so 2 implants on either side of the zygoma, and immediately load this. So it takes about 2 days for the technician to manufacture the prosthesis. I think as time goes on, the technology is improving, they'll be able to manufacture it within a day like we do for our full arch cases for normal tooth-supported rehabilitations. But the radiation oncologist is happy because now we're not delaying the treatment, because they really want to get in there and radiate the patient as soon as possible, because we know the sooner they start the treatment after resection, it improves the patient's outcome. And so they're happy, we're happy, and we know that those zygomas are going to be stable enough for the implants to integrate. And if we have any failures, what we've seen is it's generally because the zygoma was too thin and we've been pushing the boundaries on it. But by and large, the success rate of placing those implants into the zygoma is really predictable. And I think it's a valuable tool for especially the rehabilitation of a maxillary defect.
Yeah. Also, I have another question. You mentioned that, for example, the number of the patients in South Africa, for example, for the oncology is quite large compared to the other areas. And the treatment access for those patients is sometimes limited because of the resources or the practitioners, shortage of practitioners, or maybe other reasons. But do you think that technology can help those kind of patients by remote treatment or remote guidance for the local dentist, that they need to provide such complex rehabilitation for those kind of patients?
Definitely. I think you hit the nail on the head. Then this is where technology needs to take us, because you don't need to have the expertise right there with you every step of the way. And I think during COVID, we've realized that where we had doctors across the world talking to other doctors remotely, getting guidance as they were treating patients. And I think with in South Africa and other areas where there's limited resources, similar approaches can be employed, where the MDT doesn't have to be in the same province, the same country. It can be wherever the expertise lie, and everybody can pool in and tap into those resources. And I think we shouldn't lose the momentum created by the pandemic. There's always a silver lining to all clouds, my granny used to say, and I think that's one of the silver linings.
Yeah. That's great. That's great. So, audience, I think we don't have any further questions. So, I would like to, so as tradition in Digitodontics, we would like to introduce a certificate of appreciation. We hereby express our sincere appreciation to Dr. Noland Naidoo in recognition of his contribution as a live webinar speaker for the Digitodontics Webinar Series on the topic of digital pathways to improve efficiency in the management of head and neck oncology rehabilitations, that was presented on Thursday, June 22nd, 2023. So, Noland, from my bottom of heart, I thank you for the effort and the time that you shared with us, very valuable cases and presented very complex cases. And those kind of cases sincerely touch our hearts because we know that those kind of patients are suffering. And once we provide them with the treatment, they really, their life is changing to and the quality of life is changing to the better. So thank you so much, Noland.
Thank you for allowing me to share, and thank you for having me. It was a real privilege.
Thank you so much. Okay, everyone, thank you so much for your attendees today. It was a very nice from Dr. Noland to share with us his experience. Please stay tuned for the next webinars. We have a bunch of webinars that will be presented in the next few weeks, talking about different digital technologies in the field of dentistry in general. So stay tuned and see you in the next webinar. Have a nice day, nice afternoon, a nice evening. Bye-bye, everyone. Bye now.
Bye.